Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, let's dive into a core topic in pharmacology, psychosis and the antipsychotics we use to treat it. Our goal here is to really build a solid foundation, to go way beyond just memorizing drug names and actually understand how these powerful medications work. So, let's get started. Here's our game plan. We'll start with what psychosis actually is. Then we'll look at the first-generation typical antipsychotics, move on to the newer atypicals, and then we'll switch gears a bit to talk about lithium. And we'll wrap it all up with some key clinical pearls to make sure this stuff sticks for your exams. Okay, first things first. Before we can even talk about the drugs, we have to have a really clear picture of the condition they're designed to treat. So, what exactly is psychosis? At its absolute core, psychosis is a break from reality. It's that simple and that profound. This is the fundamental problem that we're trying to correct with our drugs. So, what does a break from reality actually look like for a patient? Well, it shows up in a few key ways. You have hallucinations, which are sensory experiences without any real stimulus. Hearing voices, seeing things that aren't there. Then you have delusions, which are different. These are deeply held false beliefs, like being convinced you have superpowers or that someone is plotting against you. Put that together with disorganized speech and behavior, and those are the symptoms we're targeting. So, what's going on in the brain to cause all this? The leading theory, and this is absolutely crucial, is the dopamine hypothesis. The idea is that psychosis is caused by too much dopamine activity, specifically in one pathway of the brain called the mesolimbic system. This theory is the key that unlocks how our first big class of drugs works. And that brings us to our first drug class, the typical antipsychotics. You can think of these as the originals, the first generation, the blueprint for treating psychosis.
So the mechanism of action flows directly from that dopamine theory. If the problem is too much dopamine, what's the solution? Block the dopamine receptors. And that is exactly what they do. Every single typical antipsychotic is a dopamine D2 receptor antagonist. Now, the prototype drug, the one you've got to know for exams because it represents the whole class, is chlorpromazine. If you understand chlorpromazine, you understand the whole group.
This right here is such a critical concept. Blocking D2 receptors doesn't just happen in one place. Depending on where in the brain that blockade occurs, you get a totally different effect. So, in the mesolimbic system, great, you get the antipsychotic action you want. But in the chemoreceptor trigger zone, you get an anti-nausea effect. In the hypothalamus, you start messing with hormones. And most importantly for this class, when you block D2 in the basal ganglia, you get major movement side effects.
And here they are. These are those movement disorders, collectively known as extrapyramidal side effects, or EPS. This is super high-yield stuff. It can be anything from akathisia, which is this horrible inner restlessness, to a full-blown drug-induced Parkinsonism. But the one we really fear long-term is tardive dyskinesia, those involuntary chewing or tongue movements that, unfortunately, can become permanent.
Now, there is one side effect that isn't just bad. It's a full-blown medical emergency, and that's neuroleptic malignant syndrome. The classic signs you have to spot are extreme muscle rigidity. We call it lead pipe rigidity, and a very high fever. This is a red flag condition, and you treat it with the muscle relaxant, dantrolene.
Now, not all typicals are the same. We split them into low potency and high potency. Low potency drugs, like our prototype chlorpromazine, actually cause less of those nasty extrapyramidal symptoms, but they cause more autonomic side effects like dry mouth and dizziness. High potency drugs like haloperidol, they're the exact opposite. You get a much higher risk of EPS, but fewer of those other side effects, which might make them a better choice for certain patients.
The really significant side effects of the typicals, especially those movement disorders, were a huge problem. And that's what really pushed pharmacology to develop a new and better class. So let's look at the next step in the evolution, the atypical antipsychotics.
So what makes these drugs atypical? What's the big difference? It's all about the mechanism. They still block dopamine D2 receptors, but they add a new trick. They also block serotonin receptors, specifically the 5-HT2A type. This dual action is the game changer. It totally refines what the drug does and the side effects it causes. And this better mechanism leads directly to some huge clinical advantages. The biggest one, a much, much lower risk of those awful extrapyramidal side effects. They're also better at treating the so-called negative symptoms of schizophrenia, things like apathy and social withdrawal, which the typicals really don't touch. Okay, inside the atypicals, there's one drug that's a massive exam pearl, clozapine. This is our most effective antipsychotic, period. We save it for cases where nothing else works, but it comes with a huge risk. Agranulocytosis, which is a catastrophic drop in white blood cells that can be fatal. And because of that, any patient on clozapine absolutely must have their blood checked every single week. Okay, let's shift gears now to a related but different topic. For bipolar disorder, while we might use antipsychotics for acute mania, the long-term workhorse of treatment is a totally different kind of drug called a mood stabilizer. And the prototype here is lithium.
If you remember just one single thing about lithium, let it be this number range. This is its therapeutic window. If the level is below 0.5, it's probably not working. If it gets much above 1.5, it can be toxic. This incredibly tight window between a helpful dose and a dangerous dose is what we call a narrow therapeutic index, and it defines absolutely everything about how we use this drug safely.
And because of that narrow window, you have to be constantly watching for toxicity. The early signs can be pretty subtle, a fine tremor, some nausea. But as the levels climb, you start seeing big effects on the kidneys and the thyroid. And in acute toxicity, things get really bad. Coarse tremors, confusion, even coma. This is exactly why checking serum levels isn't optional, it's mandatory.
So how does someone become toxic on lithium? Well, this is a classic drug interaction you have to know. Lithium is an ion, and chemically, it looks a whole lot like sodium to the body. So if a patient gets dehydrated or takes a diuretic and becomes low on sodium, what do the kidneys do? They panic and try to reabsorb as much sodium as they can. The problem is they accidentally grab a bunch of lithium along with it, and boom, the lithium level in the blood shoots up into the toxic range.
Okay, let's pull all of this together. This is where we lock in the most important, high-yield points for each of these drug classes. This table right here is pure gold for studying. For typicals, think EPS. The key side effect is extrapyramidal symptoms. For atypicals, the big concern is metabolic syndrome, things like weight gain and diabetes. But you always have to remember that special case, clozapine, which needs WBC monitoring. And for lithium, it's all about the kidneys and the thyroid. So you have to monitor serum lithium levels and check renal and thyroid function. So we'll end with a final clinical challenge to put it all together. You've got a patient on haloperidol, a high-potency typical. They suddenly develop a crazy high fever, that lead pipe muscle rigidity we talked about, and they're confused. Based on everything we just covered, what is this life-threatening reaction called, and what's the one treatment you have to give? Really thinking through these scenarios, that's what takes you from just knowing the facts to truly mastering the material.